A very warm welcome to everybody, and thank you for logging into the VKN Road to Recovery on the session for rehabilitation of homeless mentally ill. We'll start with a round of introductions first. From our side, we will start off. Can I request Dr. KP to?
I'm Dr. Krishna Prasad. I'm a faculty in the Psychiatric Rehabilitation Services here.
I'm Dr. Harish. I'm working as assistant professor in the Psychiatric Rehabilitation.
I'm Dr. Jagannathan. I'm a professor of psychiatry and I also work in the Psychiatric Rehabilitation Services.
I am Aarti Jagannathan. I'm working as an assistant professor in psychiatric social work with the Psychiatric Rehabilitation Services.
I'm Naveen, I'm Associate Professor of Psychiatry and a member of the Psychiatric Rehab Services of NIMHANS.
Good afternoon. I'm Dr. Kumar. I'm Assistant Professor of Psychiatric Rehabilitation, NIMHANS Bangalore.
I'm Dr. Arun Garat, Senior Resident in Psychiatric Rehabilitation.
I'm Dr. Abhishek Pathak. I'm Senior Resident.
Very good. I don't think they can
Satish.
hear. You can.
Mic is here.
Mic is here. You just turn in this side.
Speak on.
I'm Dr. Satish. I'm doing my fellowship in psychiatry.
Thank you. Could I request the people who are online to introduce themselves one by one? Could I request the Chittadhama team to please introduce themselves to the entire audience online? I would request others to please mute yourself. Yes, sir. Please go ahead.
I'm Dr. Ravishankar. I'm at Chittadhama.
I'm Dr. Murali. Currently, I'm working in the Ramaiah Hospital, Medical College, and also Secretary of Chittadhama now. Similarly, I'm also Secretary General of the World Association for Psychosocial Rehabilitation. That's all.
Thank you, sir. Could I think Chelamuthu Trust is also online? Can I request Chelamuthu Trust to please introduce their team members? I would request the others to please mute themselves.
Good afternoon, everyone not present here. Greetings from MS Chelamuthu Trust and Research Foundation. I am Sahai Raj, working as a psychiatric social worker in our rehabilitation center.
Good afternoon to all. I am Jairaj, working as a psychiatric social worker in MS Chelamuthu Trust.
I am Muttumari. I am working as a psychiatric social worker in MS Chelamuthu Trust.
Thank you. Any other people over there with you, Chelamuthu Trust, or just the three of you?
No,
Okay. Thank you so much and welcome. I can see the Pushpagiri team also online. Could you please introduce yourself? Set. We will first have the presentation by the Chittadhama team by Dr. Murali, followed by Dr. Ravishankar Rao. So I now hand over the proceedings for presentation to the Chittadhama team.
Inviting us to have a presentation of the experience of persons with mental illness who are homeless. And at the outset, I would like to wish all the participants a happy Onam and Vara Mahalakshmi. Chittadhama is an experience in the sense that this is the first facility probably in the whole of India where to start by psychiatrists, initiated by psychiatrists. And that also, there are a lot of private practitioners who are involved in this process. Now, this is Chittadhama is the name of the facility where our main trust is Chittaprakasha Charitable Trust. And you can see the names of people who are there spread over different parts of the country. Now, when we started this facility, there are a lot of experiences which we had gone through where difficulties came in. One is land regulatory issues. In Karnataka, you are not supposed to get agricultural land by a non-agriculturist. So these issues are tackled over a period of time. And then we have to follow the Mental Health Act, and as all of you know that there are no specific mention of psychiatric rehabilitation word in the Mental Health Act, but there is a convalescent home. So you will get a license as a facility to run psychiatric hospital, bar, nursing home. But we come under the convalescence home, actually, as per the Karnataka state rules. Now, licensing was not a difficult thing because we are having an excellent mental health authority secretary who is very, very forward looking. Staff recruitment and training was another issue which came in because the place is situated in a remote area of Karnataka, 6 kilometers from HD Kotte, Hegadevan Kotte in Karnataka. And so we have to get local staff who can stay there, who can come from their home, and again, anybody from city do not come and join the place. So we also have a policy of appointing staff from the local area. The other important issue is that to start something in a village area, we have to have liaison with public functionaries and completely local community. Now you can see, look at the pictures of the facility around, because we generally look at agricultural based programs. And this building, which was donated by Infosys Foundation, and thanks to Infosys Foundation for giving us this building, and which is around 7,000 square feet. Now these beds, you can see that it's a picture of the male ward. Any day, anybody can walk in, and this will be the situation during the daytime. We do not usually allow people to, unless person is very sick, to be inside the rooms. This is a kitchen and a store. Now, the 4 hours to recovery can be rescue is the first procedure. Now, sensitizing judiciary, police, and the community. We have conducted a workshop with the Mysore City Corporation, and we have got an understanding with the Mysore City Corporation. A MOU has been signed, basically to rescue people in the Mysore district only. Then we have to do sensitization of the police. The whole police people have been sensitized there. Similarly, the community. Because people had a doubt, what is his interest of rescuing people who are homeless, and these people may be having some other benefit. So the center is actually open to all the community members. Whoever can come and visit the place, they are free to visit, and it's a totally open facility. Now restitution is basically treatment issues, and you know that when a homeless person is taken to us, there is no history available. Everything evolves over a period of time. Now, rehabilitation process is predominantly agriculture, dairy, kitchen, then housekeeping. These are the areas where we concentrate. And reintegration is the last part. Acceptance, reluctance to acceptance, rejection, and trace. This will be discussed in the case later. Now, natural therapy is what we are having: activity scheduling, behavioral modification, body training, group therapies, vocational training. As you have seen the trustees' names, we have psychologists, social workers, as well as psychiatrists and philanthropists in the trusteeship. Now, rehabilitation process in Chittaprakasha is first is personal hygiene, and once a person is rescued, there are instances where government hospitals do not even clean them. So they are being sent directly to us, and we have to initially start shaving, then giving bath, then not giving good food to start with. After that only we will start medication. Activities of daily living skills, then vocational training, recreation, and pet therapy. Now you can see the recreation program which is being done. So the whole area is around 4.5 acres. Now, the beauty of this place is that it is situated near a big lake. And these are some of the agricultural activities which you can see that. And today, if you go to Chittadama, it is so green, and because of thanks to good rainfall this year. And we also have cattle, and we also train women who are there for kitchen work, and some of them also assist the staff. Dairy, and then pet therapy. We are having mainly rabbits, and patients also become very, very comfortable with this. Journey so far has been that we have admitted till now, from the start of Chittadama functional in 2010, total number is 67, male is 46, female 21. Presently there are 27 inmates, male 16, female 11. And people who are reintegrated state-wise, you can see that Tamil Nadu 6, Kerala 3, Karnataka 22, Uttar Pradesh, Maharashtra and Bihar. And we had 3 people who walked away from our place. Because as I told that it's an open place, so they just walked out. And 2 people unfortunately died. One of them was very old. The other person was a young person who developed tuberculosis. Now, provision of funds. This is generally talking about that for a mental health rehabilitation, it's not that it's very easy to get money from any of the government agencies or any of the major programs. So we have to really look at social, even though it is written in the National Mental Health Policy, it is very, very hard, difficult to come. Now, staff pattern has been asked at that time of circulating our slides. We are currently having 9 staff, out of which 1 is a qualified social worker with who acts as a PRO manager, as well as the person who liaisons with the community and the police. And we have 2 qualified nurses who are from the local area, and there is a chief cook, assistant cook, and there is an assistant for managing agricultural activities. Now, most important thing here is that all of them are doing multitasking, because caregiving, cleaning and all those things are being done by all the staff, irrespective of what is their position. So that way the staff structure is all right. All the professional support is given by the trustees, as well as a few of our well-wishers from Mysore Medical College, JSS, MS Ramaiah, Ambedkar. So we are having a large number of support services coming from various facilities. So that's the way the thing goes in. I'll try to stop here because we can have more discussions when the questions come in. Thank you.
Next. I think we'll go on to the next presentation. This is that we've kind of seen at Chittadama in the last 2-3 years. One is what we talk of as a successful rehabilitation, and the other one is of problems that we had. Now, the first process of rescue. This happens generally there where the local people inform the HT Kote police station about a wandering person with mental illness. They would have just seen him wandering over there. And this person was about 4 kilometers from HT Kote at a place called Handpost. And the police then informed Chittadama, and one of our caregivers went along with the team and police to rescue this person, who was a male aged about 25 years. He was, with the help of the police, he was taken and produced before the civil judge at the Judicial Magistrate First Class, HT Kote. And from here, they sent this person, the patient, along with our caregiver and the police, to Care Hospital, Mysore, because they had said that although we had psychiatrists over here, we could not assess them because there was a conflict of interest. So they're taken to the psychiatric department at Mysore, and a medical certificate is issued by Care Hospital, which is submitted to the judge along with Form 8. That is, we had supplied an application for a reception order from our side. Based on this, the judge issued a reception order, and with this, he was admitted to Chittadama on the 23rd of January 2013. And later on, a file was opened in Form 6, that is, which has a pro forma of the case record. At that point in time, when he came in, we saw a shabby-looking 25-year-old with long unkempt hair, dirty clothes. He had very poor personal care, and he was quite abusive and aggressive. His psychomotor activity was increased, and we found him talking to himself, and he would not answer any of our questions. So much so, we did not even know his name. He was quite irritable, aggressive, and he would attack without provocation. At Chittadama, he was coaxed and convinced to have a shave and be assisted in bathing. And all this is done keeping in mind the person's dignity. Nothing is forced on him. We kind of just coax him to do all these things. He was given a fresh set of clothes. And what is striking when these people come in is they're from the area where all this is done, they're taken into the dining room and they're given a hot meal. And these people they cannot believe what they are seeing. For the first time, they're probably seeing a hot meal on a plate and they're sitting down on a table and eating. After this assessment, he started off on olanzapine, haloperidol and diazepam. And everybody who comes in there has certain baseline blood investigations done. This includes a complete blood count, random blood sugar, hepatitis B, and we have an arrangement with the Vivekananda Memorial Hospital at Sargur, where they have the HIV surveillance cell, where these investigations like VDRL and HIV 1 and 2 are done. This is done for all the patients. At the same time, we had a broad idea as to what kind of psychosocial interventions that we were going to do. At that point in time, a needs assessment, and we like to mention here that we don't use any scales as such. And this is an ongoing process. At different points in time, a person is able to do certain things and not, and that is assessed by our staff from time to time. And there is a kind of a activity scheduling that goes on from the time the person comes in. And as I said, depending upon what he's able to do at that point in time, he's encouraged or he's coaxed or he's kind of trained to do it. This is taking care of his personal care right from the time he wakes up in the morning, making his bed, going out, brushing his teeth, washing his face. Now, this may appear so simple, making his bed, brushing his teeth and washing his face. Now, one should know that this is something that these people haven't done for a long, long time. And after that, in the morning, they are taken for a yoga class, and some exercises are done. They come back, they say the morning prayer, and they go on to have the tea and breakfast. After this, they are taken on to the field to do some agricultural activity. That's people who can do it. And they come back, they have the lunch and the rest, and the evening it is recreation and playtime, and at about 6 o'clock it's TV watching time, followed by dinner. Now, all these things are done at different points in time, depending on how prepared the person is or how capable the person is of doing all these things. This is something which Murali has already mentioned, and this goes on simultaneously or concurrently. Now, when he first came in, this is 17 days later, I'm mentioning the mental state examination findings. A person, then we realized, was speaking in Tamil. And by the time he had quietened, he was looking quite rested, and he would be sleeping a lot more than what he should have been doing. At times, he was found talking to himself, and he would answer minimally, and simple questions were relevantly answered. He would complain of fear, but he could not elaborate what it was due to. He could not recall his address or his father's name. And there we realized that he could tell us what his name was, and this was different from the one that was recorded on the reception order. He was able to tell us his late mother's name and that he had 4 siblings, but he was unable to recall their names. And this is almost 2 months later. There's been a gradual improvement. He's cooperative. He's taking part in the ward activity. He's able to care for himself. He makes his bed. He follows the dining room etiquette. Our dining room etiquette would mean that all of them sit down, get their plates, sit down at the dining table, and quietly sit down till somebody tells them that they all have to stand. They say their prayer, and then they sit down, and all of them start eating at the same time. And once they finish eating, they take their plates, go wash it, put it back into the rack, and come back and clean the dining room. And then he would go out to the field to work, and we'd find that he was very fond of doing things like chopping, carrying wood to the kitchen and things like that. Most of the time he would be quiet, and we found grinding his teeth. Sometimes he's found talking and smiling to himself, but then he had become more communicative. 7 months later, we find that he's able to recall the name of his parents, his brothers and sisters, and he's able to tell us the name of his village and the nearby landmarks. He's quietened down now, quite cooperative, and he's taking part in ward activity, and we find him quite cheerful and communicative. By this time, one of our caregivers, Prakash, who had a lorry driver friend who, given the kind of details that our resident could give us, he was able to make contact with the family. And there we realized that his father was also a wandering person with mental illness in the village. His mother was no more, and he just had his younger brother and his aunt as guardians. Prakash visited the family in June 2014, and there he told them about our resident and educated them about his health. They told him that he was been missing for 2 years, and they said that he could not come to fetch him and requested that he be reached home. So we made preparations to send him home. The judge and the police station were informed, and Prakash took Perumal home. Once he went home, there was a very happy reunion. Everybody was happy to see him, and Prakash connected me to his brother and aunt over the phone. And then I had a conversation with them, and they revealed that he was a construction worker, and he had gone out for work with 5 others about 2 years back, and then he went missing. The family search proved very futile, and they had almost given him up for lost, or they probably thought he had died somewhere. And now they were very, very happy to have him back. The family was educated about his illness and need for a regular treatment and follow-up. And there we had to take certain documents from his people to show that we have reached him home carefully. And so we had a letter signed by his uncle, aunt and brother stating that he had been missing for 2 years, and he was admitted in Chittaprakasha, and he was treated over there, and that they had made a request and we have reached him home. And they said that they will take care of him and follow the advice regarding the future management. And just for our records and to prove the authenticity of these people, a ration card copy was taken as ID and address proof. That we do for all our residents. As an epilogue, now it is 1 year since Perumal has gone home. We write HOME in capital letters because that is what was missing for 2 whole years. He takes his medicine regularly and follows up with a psychiatrist, and he goes to work as a construction laborer. He was in this to start with. He stays with his family. One of our caregivers continues to stay in touch with him and his family over the phone. Now, this is about a successful rehab that was done. Should I go on to the next case right away?
I think, Dr. Ravishankar, we can pause a bit for some discussion and questions, especially.
Tongue is Tamil, and that is how he was able to connect with, and he stays near Coimbatore, where our patient is also, our resident was also staying. So that way there was a contact with people from that place, which he utilized.
So the term caregiver is given any specific logic, sir? You use the word caregiver, but ideally he's a staff working with you as a
caregiver. A staff there who kind of Okay, he's our the Chittadama caregiver. We call them caregivers there. People who are with the residents, who help them and who carry out all these activities. We call them as caregivers in Chittadama.
Was any Dr. Chetan?
There are two questions. One was that when you go to the community and try to rescue the persons with mental illness, there are in practicality, what are all the difficulties you face? Because they would be abusive, aggressive, as you said. Even if we take police, to get them onto the police van itself would be, or an ambulance would be difficult. How do you manage that? Like, for example, giving sedatives or trying to talk to them. What is the approach you take to rescue homeless mentally?
Yes. See, most of the people whom we have kind of, the experience has been that these people are very anxious and scared. And if you get their confidence and you're able to talk to them and try to convince them and gently coax them, you're able to do it, because we haven't had the experience of going and using sedatives in the community or on the street to kind of quieten them and get them. The moment they go with our staff and with the police, they normally, quieten down and they are willing to follow our instructions. So there's not been a time when we needed to sedate them on the streets.
Yeah, I think it's a very important piece of information, Dr. Rao, that you have given, because most people believe that the so-called wandering mentally ill people are dangerous. They can be aggressive, and it is difficult to handle them, especially given the hype about mental illness and violence that has happened recently. I think it will be nice if we can share this in the public fora also, as to how you feel that most of them could be talked to, and you could, you don't have to use any much force to get them to treatment.
That's right. We haven't had very much, except that we've had a few, humorous situations also over here, where there was a person whose house was the bus stop, the bus shelter, and he used to sleep on the bench there, and under the bench he would have all his empty bottles of water, or empty plastic bottles. And then we went there and we told him that, you see, we are from Chittadama and we have a place over there. We'd like to take care of you and then give you medication and things like that. So he just looked at us, he heard us and all that. He says, yes, you're doing a very good job. I'm busy right now. You come back next Monday, I'll come with you all. So it's been a very varied experience. Of course, we've had one or two aggressive people, but then we find that these people are very, very scared. They're very anxious, they're very scared. And once you show them that you're genuinely interested in doing something, then they kind of acquiesce.
What in the literature we have read is in other countries, what we have read is there is something called as velvet bulldozing technique. When there is a homeless mentally ill, they wouldn't go on the first day and ask them to come with them. They would go give them, assess their needs. Most common need would be food. So they would provide them food. For a period of time, they would gain trust of them, and when they ask them to come with them, then they would come. Is one of the, in the literature, what we have read. One more question.
Yep.
Yes, sir, you can go ahead.
We haven't had the need to do that. You should know that from the time we contact the person to taking him or her to the magistrate, to Mysore and back, it probably is about, say, 16 to 18 hours. So as soon as this person is detected, is seen, we put them into a cab, take him to Mysore, and in Mysore, we have an arrangement with the Department of Psychiatry where they'll attend to us soon, so that they attend it too fast and then sent back. So this is done in one single day, perhaps from sunrise to sunset. There have been instances where the police have kind of got hold of got somebody and said that you keep him here for the night, we'll come the next day and we'll pick him up. So we try to avoid that because there are a lot of legal implications over there.
The other thing which we wanted to know was what is, like how do you utilize buddies in therapy and training? The buddy training which you mentioned, can you shed more light on that?
I think Murali will talk about that. Murali.
Yeah. See, what we do is that, as I told you, even there are 27 people there, and we have 9 staff members. Patients who have improved, say, we'll call A, and we'll call the person who is having more disability as B, and A will be rewarded for the improvement shown by B. So A will supervise this person to do the personal hygiene, daily bath, all these issues. So it is A's responsibility to see that this person improves. Now we are able to do that, and over a period of time, people who improve, they improve so fast because most of them are drug naive when we get them, and the way they improve is something very enlightening for us, and they can. It has reached a stage where we also thought of even appointing one of them as a staff with us. Now, that is the type of improvement you see. So you can use these people for the buddy training program. And this probably has been described long back. If you look at some of the treating the treatment failures, that book gives a detailed description of buddy training program.
I have a question,
Thank
sir.
you. Yeah, please go ahead, Doctor.
I have a question, sir. Like in this case, it seems you have mentioned that he has been produced in front of the magistrate and reception order was taken. So not only in this case, in other cases, once you obtain the reception order and you bring back to your home, what if he refuses and what if he tries to run away? How do you handle that? Because it some legal implications, because the onus will be on you because magistrate has handed over the case to you for treatment. And at what point you decide that the reception order may not be required in this case, and he would take care of his own treatment, like willingness for treatment.
All admissions are made only through a reception order. And the point that you raised that they may come over there and they may be restless or they may want to go out and they may try. So as soon as they come over there, if a person, like in his case, we kind of started him on haloperidol right away. And the thing is got under control soon. Yes, we've had people who are absconded. In our statistics, we showed you 3 people who had absconded. And once they are absconded, there are FIRs that are registered against our caregivers. When we went to tell the police that these people are absconding, they said, okay, now we're going to file an FIR, and that FIR is still there.
I think MS Chellamuthu Trust has a question they have put in a chat. Maybe you can unmute yourself and ask the question, MS Chellamuthu Trust.
The people from the MS Chellamuthu Trust
maybe
wants to ask you that, do you have follow-up on these cases? Not only in this case, but who are, like you said, one from Bihar and 2 from like other states in Karnataka, Kerala. Do you have follow-up on these cases? They wanted to ask you.
No, there are no long-term follow-ups, except that the person in Maharashtra, after about a year, they kind of rang us up and told us that this guy had got married. So they wanted to share the good news. So otherwise, we don't have a long-term follow-up on people who have been reintegrated to places in Uttar Pradesh, Bihar, and things like that.
Thank you. Any other questions from online? I think, Dr. Rao, we could continue with the next case, and then we shall.
Okay, this followed the pattern of the earlier resident who you had the local people complaining to the HDK police station about a wandering person with mental illness. Again, the police informed Chittadama about Babu, who was about 50 years old. He was presented before the judicial magistrate and sent to KR hospital for medical certification. Reception order was issued on 23rd January, and after we provided Form 8, admitted to Chittadama. At Chittaprakasha, we found him particularly dirty looking. Clothes were so black and greasy, very ill-kempt, and with long beard and matted scalp hair. He was very irritable, uncooperative, and would not answer any questions. He kept insisting that he was okay and he did not want to stay over there. We kind of coaxed him and convinced him to have a shave and be assisted in bathing, and this was quite a difficult task. And we gave him a fresh set of clothes, and what they always do, they readily took the hot meal that was provided to them in the dining hall. He was also started on haloperidol, olanzapine and diazepam, and the routine blood investigations that we sent for everybody was sent for him too. And at the same time, we kind of looked at what possibly could be done by way of a psychosocial intervention, like we had done in the previous resident. There was a gradual improvement over 6 to 8 weeks of treatment. He was sleeping well, taking care of his personal hygiene, started interacting with the staff and residents, and was taking part in the everyday routines like waking up on time, making his bed, brushing his teeth, washing his face, coming to the dining hall for coffee and breakfast, going to the field to work. Now, all these things may appear such simple things, but then once you are there and the kind of life that these people have had on the streets, every single thing becomes extremely significant. He would not take part in any kind of activity, but we would sit down there and watch others playing. And over the next couple of weeks, he was able to give us details details about his family. He told us that he was living in HT Kote. That's just about 6 kilometers from the way where Chittaprakasha is, and that he was living with his brother. And he said that his clothes were dirty because he was working as a diesel generator electrician. He had a widowed sister who was also staying in HT Kote. And this sister was dependent upon her son, who was a daily wage earner and the sole breadwinner of the family. And therefore, financially not very strong. He said that he had an elder brother who had migrated to Mysore and was not in contact with the family anymore. Now, we stop here and I go to the next case history, and this is where we found, we were kind of very surprised. Again, he was found in a place called Jaipura, that is about 30 kilometers away from Handpost. This is on the way to Mysore. And the police informed us, and we went and picked him up along with the police. And the usual procedure of going to the judicial magistrate, going to Mysore for certification. And he was admitted on the 22nd of April, 2013. Again, we found that he had very ill-kempt hair, a beard, dirty clothes, extremely poor personal care, is quite withdrawn, is talking to himself, would not answer any of our questions. Again, we had to kind of, after convincing him, shave him and assist him in his bathing, given a fresh set of clothes. And of course, the mandatory hot meal. At this point, we started him on risperidone, trihexyphenidyl, and got him through the usual baseline investigations that we have, that is the CBC, RBS, HBS, AG, VDRL, HBA1 and 2. Now later, the rest of the investigations that you see on the screen, we found that about 4 or 5 months later, he developed a bilateral pedal edema and he was breathless. And that is the time we had to shift him to Vivekananda Memorial Hospital at Sargur, about 18 kilometers away, and seen by a physician, and then referred to a cardiologist at Fortis Hospital, Mysore. And we had to go through all these investigations till he was cleared of any serious physical problem. And the psychosocial interventions that we had planned, like for the other residents, kind of scheduling his activity, and all this is a process which happens over time, and it's when they're ready for it that they're kind of gently introduced to these things. And he improved over the next 10 to 12 weeks, started taking care of his personal hygiene and going to the field. This is an activity all of them like, going out into the open air. It is green, it is picturesque, and they go and do whatever little work they can do over the field. Helping in the dining room, laying the tables, laying the plates, cleaning up the place. And we found him started interacting with the other residents and the staff. At this time, he was able to give us his personal details, and he provided us information that the person history we spoke about previously, that he was his elder brother and they both had lived together. And we noticed that in the at Chittadama, there's very little interaction between them, and they would look at each other as though they were strangers. We obtained details of the address through Babu, and then they said that both of them were keen on going home. And the address that they gave us, when we went there and saw, we found that there was no home at all. But then they said that 2 years back they were living together over there. We were able to trace their elder sister, who was in HT Kote itself. But then the sister was very reluctant to accept any responsibility for both of them. She said her past experience with the illness, combined with the financial constraints that she had, she was not able to take care of them, and she would kind of just keep us away from, even suggesting that she take them back. The Chittadama team made efforts to convince them that with treatment that both of them were better and they were able to take care of themselves in that place. And we said that we would give you free medicines and we would come there and they would still be under our care since they were close by. And it took us 3 months to convince the sister to take Babu back home on a trial basis. And Babu went home after about 11 months of staying with us. He was provided with a month's supply of medicines, and he went to work as an electrician, what he was doing previous to being admitted over here. But he just went there for a month and then discontinued. We realized that there was a very poor drug adherence. And then he gradually became withdrawn and housebound. We found that there was a relapse into his earlier illness pattern. We had our staff going to the house, trying to talk to the sister, talk to him, say that we would kind of give him the medicines, but then it didn't seem to be happening. The Madan, meanwhile, the sister was definitely reluctant to take Madan back. She says one person here at home is enough. And Madan just ran away from Chittadama one day. And then after much searching, we found him in his sister's house. But then he refused to come back to Chittadama. So at this point in time, we went to the police station, we went to the magistrate, and we told them that he has improved and he's there at his sister's house, but he refuses to come back. So with their permission, we discharged them on the 30th. That is almost a year later. Almost a year and a half later. But then at home, this pattern which his brother had of poor drug adherence continued, and he also gradually became withdrawn and housebound. And then he also relapsed into his early illness pattern. Now, in spite of repeated staff visits, they did not come for a follow-up. And we tried to give them the medicines over there, but we were not very sure whether they were taking the medicines or not. And then we said we would kind of give them a depot injection so that our staff would go there and give them a depot injection. But then they refused to take the depot injection. There was the nephew over there who seemed to have some kind of who was taking some kind of a responsibility, because the sister seemed quite helpless. But then when we spoke to him, he says that he's too busy with his work and he can't, he doesn't have time for any of these kind of jobs. Now both gradually have slipped back into illness, and then they're back to where we found them the first time, in the streets, wandering about in HT Kote and other places. Now, we have been making attempts to readmit them at Chittadama, but before that, we want to see that we have a lot of things in place, or try to understand why this whole situation has happened before we get them back and then they get back into the same situation. So we are looking at why is it that the family has been doing it. And then we've been coming to, we've been gradually getting information that there are more problems here than what are really visible. I think we could talk about it in our discussion. Thank you.
Thank you, Dr. Rao. And now I open the floor for any questions or discussion. Anyone want to ask any questions? I would possibly ask the first one. Do you have cases, Dr. Rao, whom you haven't been able to integrate back into their families? I mean, one of this is, of course, this case where you spoke about Madan and Babu, where the family was very reluctant. But are there cases where you've not been able to even find the family members or reintegrate, in the sense you have a lot of long-term patients with you? And what would the percentage be?
See, right now we have about 7 to 8 long-term patients among the 27. Long-term patients, because they have not been able to tell us where they are from, or even if they have given us their addresses, we have not been able to trace their addresses. Or it is possible, and there are 3 people from West Bengal who speak only Bengali, and we've had people speaking Bengali who have gone over there, and we've taken their help to try to talk to them, but then not much headway has been made. So there are these 3 people from Bengal, 2 people from near Delhi, a female from near Delhi, and other places of in Karnataka where we have not been able to send them back because they're not able to tell the addresses, or we're not able to trace the addresses given by them.
How do you basically liaison with people in Calcutta? I mean, would your staff go in, or would you liaison with people in West Bengal and Calcutta and ask their help to search the house? I mean, how does the process take place?
See, we haven't been able to get the address. Once we get the address, then probably we could find out ways in which we could kind of liaise with people over there. We don't even have a proper address.
I meant to ask, I mean, not just about this case of West Bengal, but in any cases with respect to outside the state, how do you basically liaison and help finding the address? Do your staff go personally, or do you have liaisoning network? When you have the address with you.
See, we have a liaising network in Uttar Pradesh, where one of our psychiatrists, who's an alumni of NIMHANS, who's working over there and who works with Mother Teresa Institution for the homeless. So we have liaised with them, and we are able to reintegrate 2 people in Uttar Pradesh. And see, we had a rough address of that place with one person. And the interesting thing was, he said that if you give us this kind of address, it's not okay. You tell us which caste he belongs to. So we were able to give him the caste and all that, and he was able to kind of just place them. So that seems to be a more important way of trying to get people in Uttar Pradesh and Bihar.
Did you take help of any governmental agencies, like of the states, like ministry, the departments of social justice and empowerment? I thought it is their duty, if we are able to convince them that they are from this state. I think the governmental agencies should be able to have their network in the state to be able to place them back. Did you work with the governmental agencies at all?
See, my experience with a large number of facility in Kerala, where homeless mentally are there, you find people from various states, and even officially from one of the center I can tell is that Cochin Corporation is running a facility which was started by the Maharaja of Cochin long back for wandering people, whether mental illness or whatever it is. That place, we tried to contact various governmental agencies, and none of these ministries were interested, these people were interested to help us. Now, what we have found in Chittaprakasha is that very simple. We are having a much larger network. Dr. Alok sir is there in Delhi, and is one of the trustees. And similarly, we are also having a network of people who have finished IIT, some alumni of IIT. They found out a group of people. So like that, we are trying to take help from various agencies so that our reintegration becomes successful. Because if you wait for any of the government agencies, it is a very, very cumbersome procedure. As I told you about the thing, about the funding.
I was just trying to have a check mark that this has been, I have asked this, because I know that it's very difficult and government agencies are not very cooperative. I just wanted to have it from your experience also. I mean, I don't know, at some level we should be talking to the governments about such difficulties that we have practically found. I know that it's a long way, but I think we should have systems in place, and issues like this can be handled by individuals and NGOs to some extent. But I think in the larger interests of the society and these kind of people, there should be systems in place. I'm just voicing my concern. I think it's a Herculean task to involve the governmental agencies in this.
Jagdish, you are true in talking about this by Infosys Foundation, and they are providing free medicines for all the inmates, as well as they're running 2 outpatients in a month. They are on 2nd Sunday and 4th Sunday, and now the outpatient attendance has gone up to something like 40 to 45, that number. So once you provide free medication, people will come and take it, and they do not have a problem with the thing. And so that's what I'm telling. It's next to impossible to depend on any of the government systems. What you are talking is true, because systems have to be in place.
Thank you. I think Dr. Chittaprakasha has a question. Please go ahead.
Sir, integration with the back into the community might be a very utopian goal in every case. But from a practical point of view, what are the different methods to get the address in these patients, and what are the steps that can be taken to reach the family members, particularly for these homeless mentally?
Yes. In Tamil Nadu, we have been liaising with a group in Trichy to cover that entire area. And in fact, we have reintegrated 3 of our people using the infrastructure that they have. They are also working with the homeless. And similarly, there is one in Maharashtra near Pune. And like Dr. Murali was mentioning, we had a group of IIT people who had their alumni spread all over the place, and they had a Yahoo group, and through that we kind of bounced one address, and suddenly somebody from Maharashtra picked it up and said it is here. So we were able to send them over there. Very often, I think once we even get a little bit of the address with landmarks, asking them about landmarks, railway stations, nearby railway stations, or a temple nearby, we are able to kind of bring, try to bring about some kind of, have some kind of idea about the address. So people who are stuck with us are not able to tell us anything, so that we are not able to move forward at all.
Some of the systems that at least in the closed ward we had been able to use for the BSNL. The BSNL website of the BSNL actually provides address-wise and number-wise detail. That was some of the things that we found useful. Also, the postal department sometimes cooperates, police, and also calling the important people in the village, and also other websites such as the Election Commission's website, where voter IDs and some details of if the person is able to provide some of the details, these are some things that we can actually do. These were in select cases very beneficial in some of the wandering mentally ill that were brought to a hospital system like NIMHANS.
Any other questions?
I have a question on the ethics of doing HIV testing. We are expected to do pre-counseling, but we have patients who are not in a position to go through a pre-counseling. I don't know. I mean, it's a tough question, but how do you respond to that question? I don't think we can wait for them to get better and then do a pre-counseling and then do HIV testing.
That's right. In fact, we have one lady with us. She looks like she's 30, and she was found in the streets and probably serially sexually abused. she's come in. She was HIV. She's HIV positive, and when she came in to Chittadama, it was a big challenge. That was the first HIV positive case, and she was not in a. She's still not in a position to even tell her name. And moment, the time when she was having her menstrual period and then was not able to take care of herself, we were not too sure what was happening then. It's only later we realized that we are dealing with a huge big problem. And she's under observation now for 1.5 years at Sargur, and recently we've started, since the CD4 cell count fell and all that, we've started on ART. So we can't wait.
Yeah.
I'll add one more thing in the, this is true. We have a very good support from Swami Vivekananda Memorial Hospital there. They have a so the patient tries to improve. That is one issue. The other ethical issue comes is that now with the reception order, a patient is being brought, then whose responsibility will come? Because Chittadama people are supposed to be, the team has to be the guardians till the person is taken. So that way we have a responsibility for doing this legally.
Okay.
I think that clears the doubt, no?
Yeah.
If you feel that issue in that, you can raise that, because we also have this difficulty of handling certain problem when it comes.
I don't know how correct I would be by saying that the legal issues seem to override ethical issues over here. And of course, clinical issues come first.
Yes. I agree with you. I just wanted to check whether you also have a similar opinion.
What are the physical health issues you face when people come afresh? And what is the protocol you go through? Because the needs can be pretty complex. A person having scabies who requires a dermatologist consultation, or a person who has got a gangrenous foot who requires periodic dressing. So how do you go about handling this? What has been your experience?
Yeah, this is very interesting question. Sometimes, I don't know how many of you have seen or experienced this. I have the experience of even getting people with maggots. And that's the type of people who sometimes you get from the road. Now, multiple physical problems are there. We have a liaison with local hospitals, and we have a liaison with Taluk Hospital, so that they can go to the SD Kotte government hospital to get these things rectified. Similarly, we are also having a doctor visiting from SUIM, Sargur, who is doing a free service for us. And he also takes care of these issues when the patient comes. And his visit is more frequent than our visit of once in 2 weeks. So unless we be liaison with multiple people, it's very difficult. And we have to get them involved in various things. Scabies, lice, body lice, then hair lice. These are the big common thing. And then matted hair. Some of them may be having a lot of fungus. So all these issues are a serious problem. Similarly, sometimes you may get people with other disabilities, physical disability. We have people with physical disability, where what we have done is that we have got them a prosthetic type of a thing for fixing the hand, so that boy is able to pick up things and work with that. So we have a lot of support from SUIM, the Taluk Hospital. Then that there is another private hospital run by sisters. So all these places we are utilizing.
Sir, how did you manage to gain the acceptance of the community as well as work with the legal system? Because it is going to be a challenge. You want to open up a home in an agrarian area where there may be a lot of myths. There will be stiff resistance from the local community.
Yeah, actually, this is actually, if you ask this, raised a very big issue because Dr. Ravi, myself, and Joni, three of us were going through SD Kotte in 2004 when I was placed, because there is a lake and a beautiful place. So we immediately purchased it, and judiciary and the corporators, the local village leaders, And we got all of them involved in it because we invite all of them for mental health day, World Disabled Day, or Independence Day, Republic Day. All these places, these local people are invited as chief guests and things like that. Similarly, the Panchayat members are also being called because we have a meeting with 20 officials of different panchayats. So they all are involved in that. The other important thing is that in Chittadama, if you are coming, visiting the place on during the time of lunch, breakfast, or something like that, they will also get served. The local people, if they come to see the place, they will also get that food. You may ask why we have to give it. So that's a way in any house. If you go to a village, any house you go at that time, they will offer you. So we also follow the same way.
Thank you so much. I think we've had a good discussion. We'll now move on to the didactic session by Dr. Naveen. He will be speaking on the legal issues which are faced by homeless mentally ill people. I'll hand over the session to Dr. Naveen.
Thank you, Dr. Aarti, and good afternoon, everyone. When Siva asked me to present on this topic, I just thought about it, and I thought the legal issues in rehabilitation of homeless mentally ill. So every facet of this particular person, will have legal implications. That is what I thought. So instead of concentrating on one or two legal issues, I thought I'll present, what all things are relevant according to what I thought about the homeless mentally ill, and raise some points for discussion. So I will be taking about 15 minutes max, and then we can have a discussion about it. So what I'll be, although my the title says legal issues, some of the issues may not be directly related to the legal angle. Next. Okay, so I would be talking a couple of slides on general aspects of the homeless mentally ill in our country. Then I would be talking about the numbers, how many of them are homeless, and issues like that, and what all pathways leads towards homelessness. And I'll talk about the services that are available for the homeless mentally ill, and of course, and then next concentrate on the core legal issues that are related to homeless mentally ill, and then I would conclude my presentation. Now, homelessness and mental illness are inextricably interlinked. It's a global phenomena. It's not only related to developing countries such as ours. In fact, much more information is available on HMI in developed countries. When we compare, absolutely, it's a very less of academic data which is there in our country regarding homelessness. Homelessness can be both a consequence as well as a cause of mental illness. This is what people say, and it's a problem for which liability lies with multiple sectors. And I think that there is no solution in sight in the near future for this particular problem. Virtually, there is no place to look after these people in our country. And presence of homelessness worsens the prognosis of mental illness, and a variety of psychiatric disorders are found in persons with homelessness, starting from psychosis, various schizophrenia, and related disorders. mood disorders, substance use, personality disorders, not to mention mental retardation, and they form the one of the most neglected members of the society. And of course, this has become a big media attention. It had got a big media attention in the recent past, about 2-3 months back, when an Indian American came and did some research in, I think, Mysore. She came and interviewed 21 homeless mentally ill persons in a residential facility in Mysore, if I am not mistaken. And she found out that the inmates had come from 4 to 5 southern Indian states, and majority had severe mental disorders. Death of the primary caregiver and abandonment by family members were the reasons for them becoming homeless. And most of them stayed for less than 20 months, and they were all united with the family members, after the effort from that particular facility. And one interesting thing that she had noticed was the moral attitude of families. There was, although they had accepted, there was some reluctance to accept women who had wandered away from homes for longer duration. Now, this she had presented in a conference, and she had won the Lancet Psychiatry Poster Award, and that this had come in all major newspapers of the country at that time. Now, this kind of media attention, I don't know how much forward the issue can move, but this is what happened about 2-3 months back. So now when it comes to the numbers, it's one has to have at least a basic idea as to what is the magnitude of the problem that we are dealing with. Now, if you go to census 2011, what it says is that about 17 lakh persons are homeless in India. Now, there is other problem here, that is, what is the definition of homelessness? There are multiple definitions of homelessness, but if you go by the census 2011, it's a simple definition, which is the lack of a living space with roof. But I don't know whether this kind of definition holds good for persons with mental illness, because their needs are different, the contexts are different. But anyway, so about 17 lakhs, that is 1.7 million, are homeless in India as of 2011. Most of the homeless are generally men. That is what data show. But how many of these 17 lakhs have mental illness? That data as of now we don't have. However, the prevalence is likely to be very high. That we are going by the Western data to support this, which say that the psychiatric morbidity range from 12 to 80%. Again, many factors are responsible for this, like, for example, deinstitutionalization, economic disadvantage, neglect from the family and society, their inability to be resilient, etc. And homeless mentally ill are many more times likely to have a psychiatric illness than the general population because of all these reasons. Now, when we look at what data India has, now way back about 40 years back, 30 years back, there was a study conducted by Sharma et al. They found a prevalence of 131, out of 1,000. That was a period prevalence of psychiatric illnesses in the so-called beggars colony at that time in Udaipur, Rajasthan. Now, when we compare this with the rates of psychiatric morbidity in India, it ranges between 58 and 73. So it's almost double. So it goes hand in hand with the Western sort of a figure, but the exact numbers we don't know as of now. Now, coming to the pathways to homelessness, mental illnesses itself can be the pathways. That is what the literature says. Most of the homeless mentally do have mental illnesses. Illnesses occur both before or after the occurrence of homelessness. Multiple illness-related factors such as cognitive factors, diminished social support, unemployment, poverty, poor familial relationships, etc. They contribute towards homelessness. Now, when it comes to the services for the homeless mentally ill, as Professor Murali and others were discussing, they're virtually non-existent in the government sector. Now, this is again a problem. The homeless mentally ill, should it come under the purview of the Health Ministry or the Social Justice Ministry? But as of now, the Social Justice Ministries and departments, they run social services complex throughout their states. they house people other than mental illnesses as well. Dr. Murali also is aware. In NIMHANS is closely associated with one such center in Bangalore, which is called as a Nirashritara Parihara Kendra, where there are about 1,000 inmates and about 60% of them do have some form of serious mental disorder. Now, they are brought to psychiatric hospitals by the law enforcing agencies or the public. They are treated and placed over there. Now, there are some government initiatives also. Like, for example, I have mentioned about NIMHANS Bangalore, the work that that has been going on. Of course, the Relief and Rehabilitation Center work in Bangalore started way back about 30-40 years back with collaboration, with Corona Trust in Mysore. So, the psychiatrists used to, even now they are visiting there once in a month or 2 times in a month. But recent experiments with the telepsychiatry have been successful there. The doctor there in Relief and Rehabilitation Center has been able to consult with specialists over here, and there has been some amount of cost effectiveness in this model of care that has gone on in the recent past. Other is in IBHAS Delhi. IBHAS Delhi has been doing this community outreach services for those mentally ill who live on payments and other homeless situations in a defined geographical area in Delhi. So apart from these, hodgepodge services for this, virtually there is no, please correct me if I am wrong, that there are no long stay facilities dedicated from the government sector to these kind of persons. But in contrast, majority of the work, with regards to homeless mentally ill has occurred through NGOs. Most residential facilities dedicated to HMI has come from NGOs. However, the models of care vary among these centers. Some cater to only mentally ill, some cater to only women, some cater to other problems as well. They are present throughout the country, but more so in southern states. Like, for example, the Home Foundation in Kolkata, Pinglaghar, Banyan, Ashadeep, Shantivanam, Shraddha Foundation, etc. Even in Karnataka, we have had a long discussion about Chittadhama, and Corona Trust is another example that I could recall. There are many others in the country. Many patients get reintegrated to their families, but what happens if families do not accept them? Now, is it not a legal issue? What are the reasons for families not accepting them? And what are the pathways to care, for such people? That, to my mind, remains a big question. So many a times patients become homeless because of the neglect and hostility by the society, including the family members. So where are the legal provisions to address these issues? It's not clear. Now, I came across another study in 2013, which occurred in King George's Medical University, Lucknow, where 140 homeless mentally ill were admitted and treated at KGMC. Out of these, 91% had mental illness. They treated these 140 people over a period of 6 years, from 2005 to 2011. And out of this 127, majority were males, illiterates, belong to lower socioeconomic strata, and they had all come from rural backgrounds. Mean duration of homelessness before hospitalization was 1 year. There's high amount of substance use comorbidity and medical comorbidity. And reintegration was possible in 70% of these patients. Of course, they had done with the help of a local NGO as well as the police departments. The authors report that families were willing to accept and support them, and inadequate treatment of their illnesses was the most common reason for homelessness. Now, the conclusion was easy accessibility of treatment and rehabilitation facilities at low cost can improve the plight of such patients. Yes, very well accepted, but it's easier said than done, considering the existent services and systems for caring of these people. Now, legal issues, proper, they affect homeless mentally ill, the families, the caretakers, and governments at multiple time points. For example, homelessness itself can become a legal issue if there is a PIL. We all know what happened after the Irwadi tragedy and the judicial intervention thereafter. Of course, we all have to accept that relatively better treatment services when compared to 15 years are present now. The NMHP and state government initiatives are there. For example, in Karnataka, there is a Super Tuesday and other initiatives have come. But why a particular person becomes homeless? If we probe into this matter, there could be legal ramifications, which I don't have. I don't think anybody has the manpower or the resources to go into such details of homeless mentally. Now, the other pertinent issues I thought was, they become they are very easily arrested for minor offences like trespassing, shoplifting, petty theft, etc. They have more than 50 times the chance of getting arrested for committing the same offence as a person who does not have mental illness. Now, Section 23 of the Mental Health Act 87, there are powers, and it's also a duty of the police officer with regards to a wandering mentally ill person to take that person into custody, produce him, in front of the judicial magistrate, and then, get him treated at, the nearby government hospital. A reception order, of course, is essential. Under Section 25, there is also a clause for protection of patients being ill-treated. Many a times in our experience, the police personnel bring them directly to hospitals. Then the hospital administration arranges for a reception order. And then there is the issue of non-criminal mentally ill inside the prisons. In a sense, they are also homeless, and which is why they have landed up in prisons. Of course, the majority of them have, petty theft cases, and there are no trials for long periods because, there is nobody to represent them. And languishing inside the jails is a very commonly noted phenomena. Of course, we are all aware of the Sheila Barse versus Union of India case where the Supreme Court prohibited the detention of mentally ill persons in jails, and orders made by unauthorized magistrates. But when we look at whether the situation has improved after this, one study was telling there were still 800 odd non-criminal mentally ill in 22 penal institutes in the state of West Bengal. Now, most of these patients were detained by unauthorized persons. Now, is this not a legal issue? How will such problems resolve? And if and when such patients are discharged into the community, where to send them, who and where to take care of them? I don't know. We don't have easy answers for these questions. Now, what does the mental health care bill talk about homeless mentally ill? There is at least the mention of homelessness or the homeless mentally ill comes in about 6 places in the entire bill. The bill says that they are entitled for free medical services at government hospitals, and they say it is their right to, they have a right to community living. And it also goes on to state that governments need to establish such facilities. Now, what do they mean by community living? Can any place outside jail be called community? And if we go and visit such rehabilitation centers, are they any better than those existent in jails? I don't know. I mean, it's for the panel to discuss about these issues. Now, then there is the issue of licensing comes. Owners need to obtain licenses to start private rehabilitation centers. Some states under the Mental Health Act it may be taken, or in some states under the PWD Act. Some state, I don't know, I may be wrong in this, but both under Mental Health Act and PWD Act. Now, there are other problems as well. Now, if one has to open a private setups, there is the Private Clinical Establishment Act. If some person needs to start something on substance use, they have to have permission under the NDPS Act. Now, so these kinds of complications are there. Now, there are other issues with licensing as well. Now, after the Erwadi tragedy, licensing of all such homes was made mandatory, but this was not implemented. Now, in 2012, a Thrissur rehabilitation home was raided by the police after neighbors complained of foul smell. Inside, 70 persons with mental illnesses were found chained. Living conditions were deplorable. Kerala High Court was petitioned by an NGO, and the State Mental Health Authority responded with a counter petition that all homes that do not become licensed will be shut down. But after that, we don't know what has happened, whether all have taken licenses or not. But obtaining license under the state law itself, is almost impossible. For example, the Kerala state as well as the Karnataka state mental health rules say that doctor-patient ratio should be 1:100. Now, we don't have a psychiatrist, even a single psychiatrist at the taluk level. Forget about one center having a doctor-patient ratio of 1:100. And we can't even think about other mental health professionals, and other staff infrastructure requirement need not be mentioned at all. all look good and ideal on paper, but confronts with ground realities that exist. Of course, I've mentioned about NDPS Act and other Private Establishments Act. These are some of the problems that are there. Now, should we propose a synchronization of various laws into single window clearance systems? What are the problems if and when we do this? Now, whatever the theoretical discussion, these centers will continue to exist in communities. That is a reality, it appears, because there is a felt need from the communities, whatever regulation one tends to bring about. And there is some provision under the National Legal Service Authority Act 1987. There's something called as National Legal Services Scheme 2010. Under this scheme, there are free legal services for persons with mental illnesses. This scheme gives some guidelines for legal services institutions such as the state, district, as well as the Taluk legal services authorities. They say that these institutions should work towards providing or making others or the government provide reasonable accommodation for homeless, mentally ill. Then they talk about right to the patient to get treatment. Visits to psychiatric institutions they are authorized to visit psychiatric institutions to ensure proper living conditions, and there are free legal services that are made available for non-criminal mentally ill persons confined in jails. Professor Murali also talked about National Mental Health Policy. The National Mental Health Policy also talks about homeless, mentally ill, and other vulnerable populations, including the non-criminal, mentally ill, and other persons. They do this gets a mention under the cross-cutting issues of the policy. Not just one. The policy says that not just one, but many sectors of the government and non-governmental sectors should be made responsible for caring these vulnerable populations. But again, I don't know when and how all these things would get implemented. So to conclude, the homeless, mentally ill, and the legal issues have multiple linkages and ramifications covering all aspects of their care and life. Woefully inadequate state mechanisms to care for such persons, an area where there is a huge number of practical barriers to bring in the mechanisms of care. Really long-term and multispectral coordination of the communities may be the way to go. Thank you.
Thank you, Dr. Naveen. I would now invite any questions, or Dr. Naveen brought in a lot of points for discussion. So whoever wants to ask in a question could possibly just raise your hand and we could start. Yes, sir, please. Please, sir, go ahead.
It's not okay.
Yes, we are.
Can you hear now?
Yes.
Naveen has brought up some interesting points, especially mentioning about the situation in Kerala state. See, they have come with rules for both the acts, and most of the I work part time there also now. So all the homes started taking both the licenses under PWD Act as well as under both the ministry it comes in, and they say that it is more difficult to follow the PWD Act. They say that it's much easier to bring in, and this was the latest which has come is Kerala state with the PWD rules for the PWD Act. Tamil Nadu came first, then Gujarat, and Karnataka still follows only the Mental Health Act. Now, the issue which has come is that because of this two licensing, people do not know which one to go for. Because Mental Health Authority also has issued a notice to all the centers that if you do not take the license, this will be cancelled. And they have put specific norms. The home where I go in Manandawadi, in that place, it's only meant for women. They told that you have to have a compound wall. And these people had 12 acres of land. To put a compound wall for these 12 acres of land is very, very difficult. So they put a small inside the thing. It's a very beautiful place, but now it is looking like a jail. And they say that you have to ensure that there is a lock, there is a gate has to be put in. And please remember, this is run by nuns, and this is a place where it's a monastery. So there itself they have safety precautions, but the government says this. So the cost escalates. It's very, very difficult. This is on donations. Now the other issue which has been told, one doubt I have is that everything, but nobody wanted to go and stay in the shelter. That's some finding which is there. So even if government makes a shelter, we have to find out why, whether will they stay there or will they go back.
Yes, sir. With
Cognitively impaired. So is it a separate group? I mean, that's what, I mean, sometimes I kind of think loud. That becomes homeless this way. And the other thing is that we've had to renew our reception orders every year.
Doesn't want to go back home. And it's a different issue if the family members do not accept, but if the patient himself doesn't want to go back home and is not cooperative in reintegration, that again becomes a situation where do we abide by the patient's decision, an individual decision taken by an individual who possibly is recovered, and where do we place him, what do we do? I think again you will have legal issues.
That's right. We have come across instances where people have said that they don't want to get back home. They say, if you want me to get back home, I'm going to run away from home and I'll be back on the streets. So we don't want to get back home. Or we've taken a person home and those people said, no, we can't take him. So I said, in that case, you get him back. We don't want him back in the streets again. So there have been such instances.
I think there's a question, Dr.
No, read it.
Okay. I think Dr. Prabhat has sent in a message saying, thanks to Dr. Rao and Dr. Murali for the excellent presentation and their work, and nice presentations by Dr. Naveen, and for bringing in important issues. Thank you, Dr. Prabhat.
See, Mysore City Corporation has done a night survey of total homeless people. And that is from evening 8 o'clock till morning 6 o'clock. This information, if you can get from the corporation, will be great help in furthering this thing. There is another agency I mentioned in my discussion that the Cochin Corporation is actually running a resettlement colony, in Cochin, which has been totally started by Maharaja. But the thing is that is for all that, it's called Beggars Colony earlier, and in that place, around 63 to 70% of the people were mentally ill, which has been helped by the Indian Psychiatric Society Kerala State Branch. Now, so we can get some information about all these issues if we are looking at this much more seriously. Look at other states also. Because you raised a very interesting issue that we do not have actually a proper system or protection for persons with mental illness who are homeless. Let's say we are using this term. The reason is that usually we don't call them homeless mentally ill. If you apply the UNCRPD, you have to address them as homeless person with mental illness. So these type of issues are there. I think it's nice that you are looking at it quite seriously, and you should be able to do that by being in NIMHANS, much easier.
Thank you, sir. I'll just see that that information is got.
Any other questions from the online board? Chelamuthu Trust, or possibly from Bhuvaneshwar. Bhuvaneshwar, yes, please go ahead. I think you will need to unmute yourself.
Yeah, we unmuted.
Yes, please go ahead. Now we can hear you.
How a general hospital psychiatrist can certify whether the patient to be sent to a state mental hospital or to a rehabilitation center?
Yeah, I think you have to take the help of the police and get a reception order to the nearest place that the court can give a reception order to. You are talking about
whether we have to certify as a psychiatrist in a general hospital, whether I have to certify that the patient to be sent to a state mental hospital or to a district rehabilitation center. So based upon which.
You will. Yeah, Harish.
I think what you are supposed to do in a state sector is you have to certify whether he is in a position to take treatment, whether he requires involuntary treatment or not. then the magistrate will take a call where to send. Only you can suggest.
Okay.
Yes, Dr.
So there are multiple centers which cater to the needs of homeless persons with mental illness. Would be interested to know how do they manage funding and what are all the problems which are there on the way, because there are certain centers which are spread across the country.
Question. Is it to me? Then I'll tell you.
Yes, yes. Please go ahead, Dr.
See, most of these so-called NGOs in Kerala and Tamil Nadu has been just rescuing straight away from the road without any magistrate's order. They have been keeping them in their places. And the number in Kerala alone was around 6,000 plus in different homes. Because we had done a survey on that and found out that the total number of beds, including mental district hospital, private hospital, and mental hospitals put together, was less than 6,000. It was 4,000 odd. So, and all the beds were full because most of the mental hospitals, all the 3 mental hospitals are overcrowded, and these people cannot go anywhere else. So, these agencies were getting funds from local public donations, and their friends and wishes, they give that. Corporate funding has not been there in any of those things in Kerala. Now, if you look at our center, we are also dependent on trustees as well as a lot of other people who are putting in the money and services. And corporate has given us basically the building, and now the medicine is coming through a different agency, but again, it is the same early corporate. Now, if you can all help us from NIMHANS to sensitize the CSR of the corporates, that will be a great help. Because anyway, government is not able to take care of these people. Only NGOs can do it. But Ministry of Welfare doesn't give any money for mental illness. Very small amount is allocated. To get this very, very difficult. Other than Asha Deep, no other organization has got it.
Yeah. Sir, I have one question to Dr. Ravishankar Rao. Sir, of the 67 patients that you mentioned, how many of them had substance use disorders? Can you tell? Because in the Western literature, nearly 80-90% of them have either alone as substance use disorder or comorbid substance use disorder. I wanted to check how is it in our situation.
We didn't have a serious problem. There was no serious problem of substance use, primarily. And of the things that we had, it was cigarette smoking or BD smoking. Hello?
Yeah. Yes, please.
It was
alcohol?
It was just tobacco. No alcohol. We haven't come across any alcohol.
Yes, sir, then you should write it up as a journal article, because it's strikingly different what you observe here in India versus what happens almost in all the developed countries. I would,
That's right.
I would urge
that.
Yeah, I would urge you to write it up as a paper.
Yeah. Jagadish, that is true. The interesting thing is that, see, in countries like well-developed countries, all of them get social security money.
Yes.
And that money, see, when I was in Los Angeles, I remember first 5 days of the month, they will spend the money on alcohol. And whoever is coming for rehabilitation projects in UCLA, evening they will all be there near a bar, because they get $5 for attending the research projects, basically social skills training projects. They will come there, attend the thing, and they are given $5. These fellows will immediately go. In India, what happens is that they don't have money. So, without money, they cannot get it. So that may be one reason that they have a lesser amount of these issues. Even cigarette BD smoking also is not a problem, because whenever they are brought there, only one patient we had a little bit of problem. He was asking for everybody begging and all that. Other than that, usually it's not there. So it is all related to that social security money which comes in. Like what has happened now is that whenever there is money given free, this can happen. And thank you for a suggestion. We'll try to write. I thought we had left a little bit of academics and got into these things.
I think Dr. Prabhat had a comment. Yes, sir, please go ahead.
No, I think Dr. Rao and Murali, my question is, you spoke about so many centers, in Kerala, Karnataka, Tamil Nadu, mostly around 100 centers. But do you think the standard quality of care has been provided there? Like SOP, you follow a standard practice. Let's see, the team in NIMHANS follows standard practice. You are being accomplished following the standard practice. But the people who are under the care of these NGOs, or even the people working on, do you think they need a hand holding? I mean, otherwise, you always look at the newspaper clips where something happened in the NGOs, something happened in the NGOs. So, any suggestion how to take it further?
Interesting.
Could you repeat that question?
Yeah. My question is there any way you can maintain a standard quality care in all the centers, at least minimum quality care in different centers you're talking about in Kerala or Tamil Nadu? Is there any way to take it further?
Okay. Now, if you have seen today's newspaper, there is a so-called rehab center has been raided. Now, lot of places people are taking mentally ill people, persons with mental illness into certain facilities without any system or law. Okay. Now, it's very difficult to say that all these NGOs which are running the facility will have standard SOP because they do not have professionals first of all. The centers which I suggested, I mentioned, even Tamil Nadu as well as Udarangarangal, all these places. Now, Banyan may be totally different because it's a professional organization. And when we talk about Chittadama, we are following certain SOP and things like that. And one request is that on behalf of Chittadama, I would like to invite all of you to visit Chittadama on any day, even without informing us. You will find that that place will be clean and neat as like what we have shown in the slide. So that type of a quality care, if you can ensure, and I'm not very sure how are we going to ensure that? Which ministry will do it?
Yes. And my suggestion is this. My suggestion is that obviously we cannot have such a standard of care. We may not get such a dedicated people who can work. But if you use something as we are using now, online technology, along with some course or some certificate, encouraging them to come to the network probably regularly, it might have some changes. And this doesn't need a lot of money, in sense, like what we are doing now. So my thing is that some certificate course with some accreditation, with expertise of yours, like in Chalamudi's trust or your trust, this knowledge can go and do a lot of good things for the people.
Some sort of a basic course, I think Dr. Prabhat is talking about, which could add on to their qualification of running their rehab center for a homeless person with mental illness. I think we have come to the closure of the session. Yes, sir, please.
Because Prabhat's thing, I just thought I'll respond. See, one course of MSc Psychosocial Rehabilitation was started in Richmond Fellowship. Now, last year onwards, the course has stopped because there are no candidates. Because after giving a certificate course, your suggestion through network, I agree. Through psychiatry, whatever it is, existing people, if they get a certificate. Other than that, you start a new course on rehabilitation, there are no takers because when they are posted with NGOs, the salary which is being given is not adequate. Now, we do not have a single iteration of staff because we are looking after the staff like any of our people, one people. So they have health insurance, they have good salary. Whenever there is a problem, we are there to support them. So no staff has left us. So your suggestion is good. If it is through a network, it's okay. But if a new course, I am not favoring it now.
Thank you, sir.
Thank you. And so I think we come to the close of today's session. We had a lot of discussion, and I would like to thank the Chittaprakasha team, Dr. Murali and Dr. Rao, for participating and for giving us an insight on how you handle cases in Chittaprakasha. And I would now request Dr. Shiv Kumar to give a brief about the next few sessions of VKN and how we are going to go about it before we close.
We thank experts who have been with us during the first schedule of 3 sessions of VKN NIMHANS ECHO R2R. Over the next 3 to 4 months, unfortunately, all the 4th Fridays on which we were scheduled to have this program, they happen to be holidays. So because of this, we propose to start the next schedule from January and hope to put up a schedule of 6 months with a galaxy of eminent speakers with participation from different centers who are working in psychiatric rehabilitation. The aim of having these sessions, as Dr. Prabhat has said, is about sharing of knowledge, learning from each other, and wisdom, which may not necessarily be available from our textbooks, and maybe create a teaching tool as well. So we look forward to meeting you again when we start the next schedule of program from January 2016 from next year. So we thank you all for your participation, and